All right, indeed. A very, very good morning to you. Thank you so much for joining us for this edition of The Tackle, being the Thursday of 8 April 2021. Tarehe ni 8 mwezi wa 4 mwaka 2021. Nashukuru sana kuonana na nyinyi tena kwa siku nyingine leo ya Thursday. Kwa kawaida tunakuanga na Diaspora Edition. Leo tunaangalia State of Healthcare in Kenya. Tunaweza kufanya mazungumzo kuhusu hali ya afya katika nchi yetu. You're going to have a discussion on the state of healthcare in this country. We're going to have Daktari MWACHONDA ambaye ni CEO na acting SG KMPDU, na Daktari GITHINJI ambaye ni group CEO AMREF Kenya. We're going to have a discussion on the state of healthcare. So we are going to have with you, we have you guys a request, as usual, a request on the journey. Please like. When you like, I get to know that you're watching us, and after you like, please share. When you share, you give someone else an opportunity to watch the broadcast. This is a tackle, and the tackle begins now. Lakini kama kawaida, kabla tujaanza, lazima tuende mbele za Mungu tuombe, alafu tukirudi tunakuja kuwapa salamu kidogo, alafu tunaingia kazini. Leo tunapiga 1 hour, sio kama kawaida tunafanyanga 2 hours, but we're going to do 1 hour kwa sababu madaktari on the frontline workers, so they're going to work on other and attend to other Kenyans. So tuende mbele za Mungu haraka upesi, alafu tukirudi tunaingia kazini. Mighty Father, we come before you this morning. We worship you, glorify your name. Thank you for another opportunity to be alive this morning. We thank you for this program. As we start to be with us, when we finish, glory and honor shall come back to your name. In Jesus' name I pray and believe. Amen and amen. Asante sana. Naona kuna watu wameamka tayari. Mheshimiwa Daisy Maritim yu hapa, Manuel Serema, asante sana. Jojo Iraki, good morning. Lucy Simayo, good morning. Cheru Jane, good morning. Lawrence Kigen, good morning. James Mutinda, good morning to you. Jojo Iraki, I can see you. Rashid Abdallah, Jamaswed, good to see you. Thank you. Good morning. I hope to see you guys. Tafadhali, when you join in, please like. When you like, I get to know that you're watching us. I would like, please share. When you share, you give someone else an opportunity to watch the broadcast. You can also send in your questions on anything to do with medical, especially COVID-19. Come on, taka mawaidha. Dr. GITHINJI was giving us an advice yesterday on how you should handle, on how you should, self-care on coronavirus, so that tuzizaza hospital na Kenya is already full. Other hospitals are also already being overwhelmed. So guys, you can send in your questions so that you're able to attend to most of your questions. You guys have been asking a lot of questions. I saw the question that was sent in yesterday after we shared our poster. So I'm also going to majorly really focus on them so that we can make this conversation very, very constructive. Haya, tutaanza na Daktari MWACHONDA. Habari ya asubuhi kaka.
Salama sana,
habari gani?
Yeah, good to see you too.
Have you doing well?
I'm well.
Yes. Unajua tumekutafuta mara mingi,
umetubounce
appointment karibu 3
since November. Yeah.
But you well. So I want to give you an opportunity to say hi to Kenyans.
Yeah.
Waambie wewe ni nani? Mbona pia unaomba kura?
Yes. We are in an election period in the union. So our role has been championing for doctors' welfare and championing for healthcare in this country, so that we have an efficient public healthcare system, because majority of Kenyans actually do seek services in the public healthcare system. Of course, the private system is also equally important, but our role is to make sure that as a union, really the average Kenyan has access to quality healthcare services and at an affordable cost, which drives into the universal healthcare agenda in this country.
Okay. Hiyo kitu unaomba ni gani?
I am the acting Secretary General, and
so
of course, where I am, it's not going to be acting anymore. We'll be actually the substantive Secretary General. Okay. Yeah, after the election.
All right. Asante sana na karibu. This is your first time on the tackle. You're going to come in again. Dr. GITHINJI, good morning, sir.
Good morning.
It's a pleasure to have you.
Thank you for inviting me.
Karibu sana. I also want to give you an opportunity to introduce yourself to Kenyans.
Yeah, so my name is Dr. GITHINJI. I'm the global CEO for AMREF Health Africa. The organization works in about 35 countries across the continent. And we have offices in Europe and North America, but we are headquartered here in Kenya, which is a pride of our organization. We work in healthcare, we work with governments, we work with private sector, we work with international donors. And our work is exactly as what Daktari has said, to ensure that Africans have lasting health change, accessible, equitable, quality, and without financial protection. And that is universal health coverage.
What has been the role of AMREF, Kenya? AMREF group in healthcare in Africa and Kenya specifically?
Well, we have been around for 63 years, actually. So I just joined AMREF about 6 years ago as the first Kenyan CEO for the organization. And the work that AMREF has done is to work with communities, to go down to the people and actually believe that people don't need charity, people need empowerment. People need to be worked with because people know their solutions. If you go to a small village in Malawi and maybe you are having challenges with water, it is not you to say we need to get a borehole here. It is those people to sit down with you and say, how can we resolve our water challenge? How do we resolve the challenge of women who cannot access skilled delivery? How do we resolve the challenge of children who are dying of diarrhea? And we find that from the founders in 1957, it's been a work of just working with communities and bridging the gap that exists between the communities and the health system. Dr. here will know that communities live very far from the health system, not necessarily geographically, even mentally, socially, financially. They're generally separated from the health system. So for a mother who is pregnant to decide, I'm going for antenatal care today, it's a long process. It's not as simple as, I know it's right for me, let me go. There's maybe a community health worker needed, talk to them, tell them why they are going and they are not sick, why do they need to go. So this is what AMREF has been doing, and this is what we reach about 12 million people a year across the continent for our work. And we don't work in any other continent. The other continents are just for fundraising, but all our focus is on the African continent.
Okay. All right. I would also request that you pull in your mic a bit so that nasikia watu wanasema wakusikie vizuri. But meanwhile, as we're waiting for you, so that I can get back to you as well. You talk about loans. There has been a conversation about loans that has been running through the country. We've seen Kenyans signing petitions online and all that. We also seen IMF giving a statement. But again, the thing is, it gave a statement, but it never said it's not going to give us money. It only gave a statement to reassure that they're going to give us the money, not to consider the kind of issues we are raising. What do you think, as a person as well who works in an institution that is really depends so much on government mechanism to work?
I think the first thing is to appreciate the fact that Kenyans are now alive. Kenyans are becoming active citizens, and by active citizenship is to interrogate what is happening internationally that affects your country. The issue about the loans, I think we all know the era of the structural adjustment programs. It was still an era of loans, and we know how much impact it had on the healthcare system, on the education system, on the social services in a country. Just this morning in the Nation, you'd see that part of the conditions to this loan is that there's going to be unraveling of new tax measures. So who's bearing the burden? It's the average Kenyan at a time when we have COVID-19 pandemic. So yes, the government needs the money, but the main concern that Kenyans are raising is the fact that we've had an old age vice in this country of corruption. And that is what Kenyans are saying, that even as you're giving us loans, give loans to a country that will be responsible for the funds, account for the funds, because we are the ones feeling the burden. So the government is using Kenyans to say that they want to provide services, to request for loans, but the Kenyans don't actually see the effect of these loans. In fact, what do they see in return? Increased taxes, increased cost of living. I mean, the fuel debate, the VAT introduction in this country into fuel is because of IMF. It was introduced as a condition, as part you're calling reform. So it is the average Kenyan who feels this pinch, and so it is important that even as the government is looking for loans, to deal with corruption the way it should be dealt with. We should see people who are culpable taken to jail, prosecuted to the conclusion. Otherwise, the noise by the Kenyans will continue.
Will they continue or hesitation? Kenya, we forget so fast. Well, Doctor, you run an organization that has rolled out healthcare measures around across Africa, in the global platform and all that. The government has been taking this money in the pretense of fixing healthcare. We'll even come back to that. But the thing is, you are in a global institution that has worked so efficiently. Do you think the government needs money or it needs structures that work? What's your feeling on the IMF loans?
Well, let me first answer your first question. Does it need money or structures that work? It needs both. The reality of the African continent, Bishop, is that we contribute only 1.7% of the global GDP. 1%. The global wealth, 1.7%. The entire continent contributes 1.7%. China and the US contribute 40%. Okay? Now, when you now do the math, and you say we only contribute 1.7% of the global wealth, how many people do we have? We have 17% of the world's population. So when you now start to then look at the nitty-gritty, you say, out of this 1.7%, which is within the 17% of the global population, how much of that 1.7% is taxable? How much of that 1.7% actually contributes to government taxes? Majority of the people, 83% in Kenya, are informal. So you have 17%. So we also have a very informal economy, which whose tax efficiency is very low. In countries in Europe, whereas those countries tax maybe up to 32, 35% of their GDP, in Africa, the average tax efficiency is 13-14% of that GDP. Never mind that we have major challenges with resource mining, for example, oil and all these things, and minerals and forestry and everything that we abuse. And there is a lot of corruption. And there is also what we call flight of money because of international organizations that work. And then, so there is a big challenge there. But generally, governments in Africa are not investing enough money in health because they don't have it to begin with. So there are several things that need to be done. One, if a government is collecting taxes, it needs to prioritize sectors which build the economy. Initially, as you're having a discussion here, in the 70s, in the 80s, and especially in the 80s, when many countries in Africa had huge loans that they had taken, and we are now kind of getting back there, the World Bank then came to Africa and said, we need to forgive you these loans, because countries were getting into a real problem. But for us to forgive you, we need to give you structural adjustment programs. Now, those structural adjustment programs are the ones that took healthcare backwards because they removed people as an investment, and they put investment to be roads and buildings and telecommunications. And investment in people like health, social services were sacrificed because of the structural adjustment programs. So basically what we are saying is this. Right now, the government needs to put more money into health because, as we've seen, health protects the economy, and then put proper governance structures that include people at the center of that governance. Governance of healthcare should be at community level. We have what we call community health committees. Those committees must be the ones that decide where the money flows and how it's used for each community. So it's both money and structures. Yes.
Okay. All right. Daktari, the question has been, we are in 2021, 1 year after coronavirus. We're still in the same place we were last year at the beginning. I mean, we're not talking about extra bed capacity. We're not talking about, right now we're talking about KNH lacking oxygen, which is a conversation that we really need to have on a very serious level. But the question is, we're still where we were. Billions of money borrowed. Our good doctors say that we need money. But yes, billions of money pumped into the economy in the pretense of fixing coronavirus or fixing healthcare. 1 year down the line, we're still where we were.
Yeah, so I think first and foremost, let me say this, that the COVID-19 pandemic has actually been a blessing in disguise. Blessing in the sense that it has caused so much catastrophe in the world. It has caused so much pain because people have lost their loved ones. That we are not saying that we are not acknowledging that, but actually it provided countries with an opportunity to strengthen their healthcare system, and not just for the pandemic, but for the long haul, and ensure what Daktari was saying, that people have access to services, people have access to quality healthcare. Now, what is the situation in our country? We did an assessment, and I've been involved we've been together, Daktari. We've been in the National Task Force, where I serve in different committees. I was in a different committee. I still serve as a technical advisor to the Health Committee of the Emergency COVID-19 Fund. We've done a lot of work. And all this, we did audits of the system. We looked at the human resources, we looked at the infrastructure, we looked at the equipment in the facilities. How are we able? And there was a team of many people who came together, including so many doctors, medical practitioners in this country. I mean, even people who do audits for systems. We all came together last year at around this time, and for months worked and put all the necessary input that was required to make the healthcare system better. But unfortunately, we're not the ones who implement this fully. The government has a responsibility to implement. And, all this was the perfect of the opportunity for the government to actually run with the UHC agenda. Because you invest in the healthcare system, you're also running your agenda. But unfortunately, where we are today, only up to 70% perhaps of the counties actually set up those isolation and treatment centers that they were supposed to have set up in terms of bed capacity. Most of them closed them down. When it comes to oxygen, we have less than 50% of the counties with adequate and what you call sustainable oxygen plants. We look at, when it comes to human resources for health, there are serious gaps, serious shortages. There's been no hiring, or there's been hiring, yes, but if you look at the terms of work given in terms of making sure that our healthcare personnel, our doctors, our nurses have access to insurance, have access to PPEs. That is still a challenge. 1 year down the line, investment in terms of ICU capacity. I mean, if you are to seriously sit back and at the end of 6 months said, we need ICU facilities, we need to expand. If it is construction, the money is being utilized the way they should have. By now, would have enough. That 1 year would have at least been able to train critical care for COVID to most of these healthcare personnel in those, crash courses, because this was a pandemic. But we are still where we were. It was just slightly different last year.
Better. It could be worse, because at the time we were talking about availability of space. Every other governor was flaunting pictures of what they've done, their spaces.
The politics.
You're saying there's no space.
The politics. It's the politics that then takes precedence here. The showcasing that we've done this, but in reality there's nothing really on the ground. So there's been an improvement, yes, but it's not the improvement that if what we had put on the table as solutions had been taken and implemented fully, the country would have been at a very much
where do you feel there's a problem, Dr. Because you're sitting in government task forces, and you also run an organization that is working well. I mean, okay, you guys use it. It's like we talk about guys who are running government business and running private business, thriving on the side and failing on this other side. Same hands doing the same thing but still failing. What do you think is a systematic failure in the system of healthcare governance? Where do you think is a problem?
That's a very complex question, actually. And I think that needs a session on its own.
Okay.
Needs a session on its own. You see, on one side, there is science, okay? Then there is filtering and developing technical advice on that science. Then there is planning. That can be all very well. Then on this other side, there's something that's called budgeting, provision of resources, and execution. Now, those two can be very different things. So, whereas in AMREF, I will do the strategy with my team, we will then allocate the budgets available, and we'll hold ourselves accountable for delivery. For us, when you're advising government, you advise government based on the science available, but you then don't go and pull the money out of treasury. And you don't actually, you develop plans, but the implementation of those plans is government based on availability of their resources. So for us, we advise, we give our voice, and many times it's listened to, sometimes it's not, and sometimes it's listened to, but there are no resources to execute. Let's take the oxygen issue for once. Last year, we went out to the counties, and the cabinet secretary appointed a team to go to the county. We visited 47 counties across the country to look at preparedness for COVID-19. That is the time that we actually were checking, do counties have isolation beds? Is there oxygen there? I remember going to a health center, we talk, and finding a nurse there in a health center, it's what we call a level 3 hospital, and saying, we had somebody come here, and it's a young man, and we took the sample for COVID test, and then after some time, he collapsed, okay? And we said, so was there anything else done? No, we are waiting for the results. The body is in the mortuary. Now, we raised this point around saying, why is it that those facilities don't have the ability to check the oxygen levels of everyone who comes, who is a COVID suspect or breathlessness or whatever it is? We recorded that in our report. Oxygen was a challenge. We have a lot of what we call oxygen production plants, as Dr. has said, that are not working. So the challenges between the advice and the execution is actually where the rubber meets the road. Yes, that's where the rubber meets the road. It's not about lack of advice. It's not about lack of technical plans. It's not about lack of who to consult. It's not about lack of knowledge. No, the government has a lot of knowledge, a lot, and very technically sound people in there. And now when you add people now like CHIBANZI and others, you have a great team. The challenge is execution. As we say,
but who executes? Who is this person called execution?
No, it's the money. You can't execute if you don't have the money. Let me say something, actually, that the government, let's look at simple programs. If you look at the HIV program and the way it was done and the communication that was done and how successful the behavior change campaigns were, it is important for people to know that most of that planning and money was actually partner-led. It was partners who execute those successful programs. Government is good at policies, it is good at regulation, but execution of policies and going out and like now we are talking about vaccines and communication. if a partner comes, the government will say, oh, yeah, please do it. But the government is not made to do that. If for some reason it just doesn't move. This is the issue. These are the issues we are having. Yeah.
So the issue is the government, not the people in government. You always talk about government.
Well, the government is the people, isn't
it? The advice, the wisdom, the knowledge in between. I mean, there seems to be a lot of very lubricated parts that seem to move, but they don't locomote.
Exactly.
Right. Okay, the question of vaccines, sir. The issue of vaccination and all that. Now, why are we monopolizing vaccination? Like we're saying, we don't, it needs to be done this way. Well, I was just saying what Biden has said, that by April, almost a bigger population of Americans would be eligible for vaccination or actually be vaccinated. In Kenya, you're talking about doing 30% by 2023. That is 3 years down the line. Now, we have locked down the country. Is it that we need more time to lock in for the next 3 years, or what is the conversation around? Because I'm imagining vaccination is in the good of the country, of the citizen. How can we ensure that we have a wide vaccination program that ensures even as we are at the lockdown, we at least vaccinate up to 30 or 40% of the population? But the question is, what is the wisdom behind the monopoly and the hoarding of vaccination?
Okay. Now, let me say this, that is very important, and I think we have to appreciate one factor, that vaccines have not been manufactured in the African continent. And what we anticipated, actually, was that this was a scenario that was anticipated because you've heard of what you call vaccine nationalism. It is a scarce resource because of the nature of which it had to be developed, the research capacity. As countries in Africa, most countries in the global south do not actually have the capacity to develop these vaccines. So each country is looking at protecting its own citizens. And that is why you're finding America, you're finding the European continent being the ones who develop these vaccines and giving priority to their people. That was the first step. So where are we as a country? I think we have to appreciate first the fact that actually we were able to secure the vaccines that we have through the COVAX facility. Okay. Because without that, we'll be talking of a different scenario, that vaccines are out there, but we do not have vaccines. So I think that is a very good thing for the country, that we were able to secure through the COVAX facility, and so now we got the doses that we got. So then the question, and that would explain why, because it was a quota type of allocation for the vaccines for each country. So now the only thing that the country can do to try and vaccinate its people faster is to now allocate resources to independently as a government procure vaccines for its people. Okay. Because the COVAX facility is funded. It is not through government resources. So that will now open up the space and have more vaccines come on board and more people get vaccinated in the shortest time possible. So again, I'd say that's now for government to look at its resources and give it a priority, not to purely depend on donor funding.
Resources you're waiting from MWACHONDA.
Yeah. Another story. Yeah. So why is it important for people to get vaccinated? And this is a discussion that we need to have for people to understand. And even as KMPDU, we are actually embarking on a nationwide vaccination campaign for people to understand why. Regardless of the efficacy of the vaccine, it doesn't really matter. What really matters is that all these vaccines, Pfizer, Moderna, Johnson & Johnson, AstraZeneca, do one thing. They stimulate your immune system to respond to COVID through the vaccine. And so as a result is, if you do get COVID itself, then you're at a better chance. It reduces your risk of contracting severe COVID disease. What is severe COVID disease? Severe COVID disease where you have severe symptoms, you have difficulty in breathing, you have to undergo oxygen supplementation, you cannot breathe normally, you go into ICU. Now if you look at the spectrum from mild, moderate to severe COVID disease, which is the biggest percentage of people who've died? The people who've died have died out of severe COVID disease, not the mild and moderate. So that is what the vaccine is trying to do, to reduce your chance of getting severe COVID disease, and so as a result of that, you will stay alive. What does it mean to average Kenyans? ICU care is expensive. So if you get severe COVID disease, you will call your neighbors, you will call your family, you will call everyone to contribute for you to cater for that.
But every other person also will be sick in the neighborhood.
Yes, every another person.
So
Right? So at the end of the day, we've lost you, you've lost your resources, you've no finances. So that is what the vaccine is supposed to do. And this is where we come in really strongly. The problem being that, again, our execution, before the vaccine rollout, read the National Deployment Vaccination Plan. Perfect document. Who developed it? A team of professionals, again. But was it executed in time? Because we waited until the vaccine has landed in the country, and then now we want to execute the vaccine. You look at it, was advocacy, social media awareness, education awareness, before you bring it on board, months before. And we knew it is coming in February. From November, December, that is what we should have done. Why am I saying this? Because the anti-vaxxers, the people who are against the vaccine, have been consistent in their message all the way from April last year. So that misconception, has percolated into people's minds, has made people have fears. Is the ministry itself, as a national ministry, coming out to say that, yes, there are reports of blood clots. But the blood clots, let's demystify it. 30 cases of blood clots out of 18 million vaccinated people, that is 0.0000167%, less than 1%. So it's a very small percentage. The rest are fine. But if you do not demystify that, what goes into people's mind? You get the vaccine, you get clots, you die. You know, and that is where the ministry really needs to focus. And we've put it's there, it's out there. We've
talking about the deployment strategy. Yes. I saw someone who was posted the other day before I get to Dr. on another question. He was saying that she was saying my father is almost 80 years old. He is predisposed because he has underlying issues. He's been trying to get vaccinated, but he's not getting vaccinated. Online, on Twitter, on Facebook, young people are flaunting pictures without shots getting vaccinated. Talk about deployment. What is the deployment strategy in terms of deploying this? Because it looks like it has been one of those class things to achieve. That's why it's so it comes with prestige to get vaccinated. And there seems to be no government strategy in
we are still Kenyans, and we are peculiar in our own way as a people. I agree, and I'll say today, I know people who've been vaccinated who were not supposed to have been vaccinated as per the deployment plan. But who's facilitating it? I mean, it's the same system that is facilitating this, because the elderly were the most vulnerable, the frontline workers, who is not just doctors, nurses, clinical officers, you have security forces, you have the teachers, who are supposed to have received this vaccination. No, you brought phase 2, which is the elderly, into phase 1. So basically you expanded the population that was supposed to have received the vaccine. But was there an elaborate plan? Even the communication, where do you get vaccines? And vaccines are not emergencies. Before you announce, make sure that even when you're announcing, say it's not an emergency, you will schedule your vaccination. So we'll schedule times between this time and this time. Create a system where I need to do is book an appointment, and I will go check. This is the appointment you had booked, we'll vaccinate you. That's how the other countries are doing it. And it is very effective. But you're in COVID and you just come out and say, now the elderly are part of this. They flock the health facilities. You have again what you call almost a super spreader crowd for vaccination. So the reality is those young people who've been vaccinated and were not supposed to have been on
they're not frontline workers. They're not security.
Yes, they're also not being fair to us. They're not being fair to us.
They're just in a place where they can access it.
I understand it's human. You want to survive, but you're being selfish. But you're not being fair to the entire country. You're not being fair to the elderly people who require this vaccine more than you. Yeah.
Okay, Dr. GITHINJI, if the agenda is to vaccinate, like Dr. said, if the agenda is to vaccinate, why do we need to keep banning other vaccines?
Why do we need to keep
banning other vaccines? The Russian vaccine has been banned.
You see,
if the agenda is to have all of us vaccinated, then we should be saying, AMREF, come vaccinate 20% of the population. You see, KMPDU, Chukweni 20%. I mean, if the agenda is to have Kenyans vaccinated, then why do we institutionalize the operations of, the medical operation?
Okay. Let me add something to what the discussion you had before. If you just need to walk to any junction in any of the roads in Nairobi and see the chaos Kenyans cause even when there are traffic lights, everyone wants to go ahead of the other person. So it's not different for the vaccines. We are generally... we generally
feeling of
a
being there
society
before the
that
other
you
guy.
want to be ahead of the other person, okay?
Before the vibe dies.
Exactly. So even if you do a plan, unless you have policemen at the traffic lights to tell people, no, don't jump, then we need to actually have a plan that replicates our duplication of resources at traffic lights, where you have traffic lights and you have police. So the plan is not enough for the ministry to say now the following people are the only ones. You need to also police that. And that's where the policing has not happened, okay? So let's look at any junction now. Let's come to vaccination. Let's come to vaccination now. This is the issue. Vaccinations are extremely sensitive, okay? Because if I actually came with water in a vial and a needle, and I told you I'm going to give you vaccine, how would you know it is genuine or not genuine? You wouldn't know.
It's the government responsibility to test the standards before
Correct.
vaccines get in. Yeah.
Thank you. It's up to the government to make sure the one that comes into the country and the one that is actually, it comes to the country, is first is regulated, it is checked, it is based on sound science. That's number one. Number two is storage and use. Actually, what people don't know is that a lot of adverse events following immunization are errors of use and administration. They're not actually related to the composition of the vaccine. We are focusing so much on this clot, and I like really what CHIBANZI has said, and focusing on this and that. But actually, a lot of the errors happen during storage and administration. So when you don't have a proper regulatory framework to ensure that a vaccine that's supposed to be kept at negative 18 actually is kept at negative 18, or one that's supposed to be negative 8 is actually under negative 8. What you may have is actually vaccines that are not effective on people, okay, but they are being given. What does that do? It affects the population level effectiveness. Because if you give 10 million people fake vaccines and you say you vaccinated your population, what is the risk on the pandemic, okay? So the failure was actually the government's in terms of there was a framework. There is actually an advisory on how private sector could participate in importation of vaccines. Because, as you say, the role of government and the interest of government and the desire is to vaccinate as many people as possible in the shortest time possible. The AstraZeneca vaccines, for your information, there was a decision to make sure they are available in both public and private hospitals, just as has been explained, the doses are very few. So these are the challenge of now allowing private sector to import. You must have a proper regulatory framework, not just an advisory, not just saying this is how you'll import. You will import this, you bring, we approve. After that, you do an indemnity or an insurance, and then after that, you're free to go. Then you find Sputnik vaccines in Kitangela in a Pro box, okay? Are you seeing where the challenge is?
But the question is, Daktari,
yes,
we knew the vaccine was coming, or there from last year. We knew we had a pandemic.
Yes.
We knew somehow the convention of vaccination was coming. We had a time to develop framework. And actually, this is a country. This is not a marketplace where every other person gets in things from each corner and brings in vaccines. We have KBS. We have Kenya Poisons and whatever board that actually regulates and checks what is brought into the country. I mean, the conference should be regulating the importation and ensuring that what we're having is a safe vaccination, a safe vaccine for the country. If we can argue that we will find a Pro box in Kitengela with Sputnik vaccine, then we are saying that the government itself is not in control of what gets into the country.
That's exactly what we are saying. That's the truth.
Okay.
The truth is that it's not only the vaccines. How many fake products do we have in this country that have KBS stamps? How many fake products do we have that have approval of the Pharmaceutical Poisons Board? How much of post-market surveillance does this country do? I'll tell you that today, if you go and register medicine, ideally what should happen is what you register is checked and then you are given a permit to go ahead and import. Now, ideally what happens in an organized system is after that, there are random checks of what you are selling and how different it is from what you registered and presented. How much resources are we putting in post-market surveillance? This is where the failures are. So the approval and regulatory can happen, but if you don't have a process of post-market surveillance or surveilling the market after you have approved the product, then you open window for people to have what they call fake Sputnik vaccines in a Pro box. And this is not a challenge of the vaccines only.
But if we have AstraZeneca, a fake AstraZeneca, is it not possible?
It can affect AstraZeneca as well. It can actually affect. You see, so this is where the government must have a very clear system, and they do, but it needs to be implemented to make sure there is actually surveillance. And I'm very happy actually that they were found. You see, the fact that the fake Sputniks were found. There was a story. There were many of them found with some Nigerians, you know. Kenya is quite alive to this kind of thing. So the fact that they were found and caught is also a way of checking that the system actually works.
Okay.
So that's what we need to extend.
All right. I have a question for you, Dr. CHIBANZI. Ask Dr. MWACHONDA, what are they planning for the doctors working in isolation centers after the expiry of the newly added 6 months contract? And what should absorb them? PHP? PNP?
Let me say this. That's a question from one of my members. And, ideally, as a union, we take care of our members. And what is more important is that we have pushed government. We have made sure that these doctors will get their contracts extended. But the question is, the position of the union is that these doctors should not actually be on contract. These are doctors who should be employed on permanent and pensionable basis. But the same government wants an elaborate and a robust COVID-19 response, but then and gives doctors 6 months contract for a pandemic that you have no idea how long it will last. But is it because of the pandemic only? It is because, not just because of the pandemic, we need these doctors for the entire healthcare system for the long haul. So that contract employment terms, decision made by the government, is a decision that we have challenged it severally, and we will keep challenging and pushing government to start seeing the bigger picture. Healthcare facilities will not end after 6 months. Kenyans will not say we don't need healthcare services after 6 months. So they need to allocate resources again for the long haul. For the healthcare system, you cannot employ people on contract. You have to employ people on permanent and pensionable basis. It is something that we are pursuing. We'll make sure that all our doctors, all our healthcare workers are employed permanent so that they serve Kenyans to the end. So that's a matter that so far the Ministry of Health gave 6 months, and this is where it becomes interesting. Council of Governors come in and say, no, shouldn't give them 6 months. Let's give them 1 year. So the national government says, we don't have the resources. We only have 6 months. The county government say, give us the money. We extend it to 1 year. So that is where this issue is. I mean, you saw that. You remember when you saw the two Kenyans from somewhere in North Rift? In Baringo, yes, in South Rift, saying, no, take this. No, I don't have. You eat. That's what's happening in this country. But who's suffering? Yes, who's suffering? It is the Kenyans. That's why we've challenged the principle of devolution of healthcare. That is the reason why. Because you have two levels of government that cannot come to coordinate and just focus on making sure that Kenyans have access to services. So it becomes a ping-pong game. It becomes a resource issue, national government, county governments. But at the end of the day, the mother in Baringo who needs healthcare services in a healthcare facility does not want to know whether national government sent money, whether county government utilized. All she wants to know is that if I am in labor and I need to deliver, and it's complicated and I need to undergo a cesarean section, I'll find a doctor in the most remote hospital in Kabartonjo, the health center, a doctor to basically just come in, do the cesarean section, get the baby out, the baby is safe, the mother goes home. That is what the average Kenyan wants. But our politicians and the people in government are playing with the lives of our people.
So on the same thing, very quickly, do you think, because there was a question that was coming up, devolution of healthcare, was it the best thing to do? And how effective has it been?
There are 3 sectors in any country that must have some serious level of centralization: education, security, and health. County governments can very well handle primary health care. The rest should now be the link between the county governments and the national government at a centralized level. So if you're talking from level 4 facilities, level 5 facilities, level 6 facilities, let the national government handle that burden. Let it allocate resources if it comes to employment, if it comes more doctors on the ground to serve people, equipment, medicine supplies. And this can be done in a very health information systems. In fact, by the way, one of the biggest challenges we've faced since the devolution of healthcare is health information management, because of that ping-pong game again. So you have a system that used to work, it needed to be strengthened, but it is not working. So we have to rethink devolution of healthcare. We can tweak it. we are not against devolution of healthcare as KMPDU, but we can tweak it to ensure that at least the county governments can focus on primary healthcare and the national government takes over the tertiary, secondary and tertiary healthcare services. And if that was the case, the COVID-19 preparedness would be different today.
Okay, it will be debatable. You can say if healthcare has always been effective in the national level. But anyway, two questions for you, sir. If one had COVID-19 and recovered, then it's supposed that our bodies has gotten the antibodies, meaning the introduction of vaccine, live attenuated, will be like the pathogens themselves, so one may get sick again. I think we should test those getting vaccines first if one has never had the disease, or if she goes first. That's the first question. The second one is, we are now at phase 3, and I understand that this corona mutates. What if the next phase comes in and you'll still revaccinate Kenyans?
Okay.
Two very interesting questions.
Yeah. So the first thing to say is that when you get infected by any virus, not only COVID, when you get infected by the flu or these things, your body calls upon its own immunity, memories and everything, and develops antibodies to ensure that it can fight that particular enemy in the body. Okay? Now, when you do that, the body actually develops antibodies and keeps some memory. Now, for COVID, what we know and what we have seen in the data is monitoring people who've been previously been infected, because there have been millions and millions across the world, that the immunity that you obtain from the natural infection is not sustainably long-lasting, and it's not strong enough. And therefore, that is why you need the vaccine, which actually then improves your own immunity, even if you had been infected before, and boosts it so that it's more long-lasting and stronger to protect you from severe disease. That's the reason why, even if you had COVID-19, you still get vaccinated. Now, the next question, I didn't understand very well. Could you repeat the second question?
Right. The second question is saying that it's actually a lady, Maslin. We are now in phase 3, yes, and I understand that this corona mutates. What if the next phase comes in? Will you still revaccinate Kenyans?
Okay, you don't need to revaccinate. Let me put it this way. You know, viruses mutate, so it's not unusual that we are getting mutations of COVID, of the coronavirus. In fact, the type of viruses that coronavirus is, which is what we call RNA viruses, mutate a lot. Human beings have DNA. Some of the viruses have RNA. They mutate a lot. How do they mutate? When they come into you, they're actually using you as a photocopy machine. So they're using your lungs and your respiratory system to multiply themselves, to photocopy themselves. In that photocopying process, they make errors. Those errors are what result in mutations. Errors that make the virus survive longer, survive more. It's like Charles Darwin. It's a theory of survival. So what happens is that they will mutate. The flu vaccine is adapted according to the influenza virus mutation over time. Now, what does that mean? It means that right now, as was explained very clearly by CHIBANZI, the most important thing right now is to stop people from getting severe disease. And because we know the current vaccines are working on what we have now, then you must vaccinate. It could be a fourth wave with the same variants. Or even if the new variants come, the vaccine which is being developed, which is specifically acting on that spike. When you've seen the photo of the coronavirus, it has spikes on top of it. Yeah, those spike proteins are the ones that actually all the vaccines are working on. So unless a mutation happens that changes
I thought it was
the
actually
shape,
designed to scare. So that's actually how it looked like.
those spike proteins, GB, are the ones that help it to attach to your cell. So unless the mutations come and change significantly those spike proteins, then it's unlikely that the vaccines will be rendered irrelevant. So we'll continue. But you know what science does? In the process, scientists are now thinking ahead and thinking in future, could this happen, and what do we need to do to prepare for it? So you don't need revaccination for the next wave. You just, once you get vaccinated now, we hope and believe that you have enough immunity to take you for several years.
Okay. Dr. There's someone who has given us a case study of one Dr. Gidero. And she's saying about Dr. Gidero post-vaccine. Can you kindly translate in layman's language? He was vaccinated and later tested positive. I also lost one very dear close friend, December 2020, who was ever so cautious and is puzzling. Where are we going wrong? I personally got my second Moderna vaccine as a frontline worker in Florida. Let's talk about the Gidero case study. You vaccinated?
Well,
Ama ilipima vaccine.
No.
Nilisikia vaccine ni corona
In
kidogo.
fact, let me say it here that I have a colleague who got vaccinated, and after 1 week, she got COVID-19 positive. But what does that tell you? She told me she had felt like initially it was the COVID vaccine, but then later realized that when she traced back, she'd come into contact with a patient who was COVID positive. And that's not the only case. So we are having people who, at the time of vaccination, remember, no one is testing for your COVID status at the time of vaccination. So there are those who've been exposed before they get the vaccine. So that's one of the scenarios. So you get exposed, you're in your incubation period before symptoms exhibit, you take the vaccine, then later you realize you have COVID. So it is not the vaccine that caused the COVID. You actually got exposed to COVID, but were not aware. Second scenario, and why am I saying this? Because how long does it take for the vaccine to be effective? So even if I got vaccinated last week on Tuesday, it takes 14 days at least. And by the time it becomes fully effective, I should have received the second dose for it to be fully effective. So that is why we are saying, once you get vaccinated, do not drop your guard. Do not stop using your mask. Do not stop saying social distancing, saying, I've been vaccinated, I won't get COVID. If you do that, you can get vaccinated today, go out in a social gathering tomorrow without observing COVID protocols, and you will test positive within 1 week after the vaccination. Why? Because you exposed yourself to the vaccine. The vaccine period has not enabled you to protect you from COVID. Until the 14 days are over and until you get your second dose, you'll be fully now protected from COVID-19. So that is the scenario. It's not just Kidero. The Meru governor was a similar story, if I'm not wrong. And this is why we're saying that take precaution. Even as you're getting vaccinated, don't drop the guard. Don't stop using this.
Yep.
Use it.
Yep.
The vaccine does not stop transmission of COVID. The vaccine reduces your risk of contracting severe COVID-19 disease. I hope I've been very clear.
Yep. I think that's clear enough, unless you still have something to add.
Yeah, I think I just wanted to emphasize that point that Tara has made, that people expect that the vaccine is stopping them from being infected. The vaccine is not a shield. The vaccine is actually creating immunity inside your body. Nothing stops the viruses from getting into your respiratory system, because the vaccine is not kind of creating a halo around you. Now, we know very well that what happens is there are some vaccines, very few, that actually create what we call sterilizing immunity, that actually stop infection. Those are the rare ones. That's the odd one out. And one of the vaccines that I know which actually stops being even infected is the human papillomavirus vaccine, which is used for cervical cancer, HPV, which is for stopping the infection of the cervix, which then creates the cancer. That's the one of the ones I can remember of my mind that actually creates sterilizing immunity. All these other vaccines, measles, flu, COVID, they never stop you from being infected. They just stop your infection from replicating to cause moderate and severe disease. So don't be surprised if you get infected after receiving the vaccine. But just get surprised if you progress to moderate and severe disease. Then we worry, because then that's really what we want, not infection. You will get infected. This is why we are saying people should need to continue wearing their masks so that they protect those others who not yet received the vaccine, until all of us, what good percentage of us, and that's what people keep asking about herd immunity, until about 70% of us, or 60-70, have received the vaccine. Then we are all protected from severe and moderate disease. Then we can drop our guard. Before that, get vaccinated. You're protected yourself, but you need to protect others in the meantime, because you're still susceptible to getting infected, but not severe disease.
Let's talk about the antibodies. I think that's something we skipped. If I have gotten COVID-19 for the first time, can I get reinfected?
Yes, that's what actually we talked about. And the gentleman asked the question around, I think the question around if I've been infected, can I be vaccinated?
No, can I get infected?
Can I get infected?
Yes.
Yes, you can. We have actually had cases of reinfection. Yeah. The issue, as I said earlier, is that natural immunity that you receive from the first infection, we do not know how long it lasts. And the general feeling is that it doesn't last very long and is not a very strong immunity. Therefore, you need to be vaccinated to protect you from proceeding to severe disease. But reinfection is possible. We have cases of reinfection that we have seen, though it's not the norm. Yes.
Okay, I'd like to read something here for you, Daktari. That is from Wathimba, Chris Paz, saying Uganda's COVID-19 cases are now so low, and yet Kenya is facing the headache of a third wave. Could it be fair to assume that having Ugandan schools closed helped to keep the spread of the virus at bay? Children are super spreaders of this virus, and having them back in school this January might be the reason we are experiencing a sudden surge in cases of COVID-19. We didn't see any surge after December holidays, but since we opened schools, something happened. These kids are not affected by the virus the way adults are, and this is something that makes them a threat in the fight against COVID-19. Ask the expert to comment on my observation.
Yeah, so let us appreciate one thing. I'll start with geographical location. Kenya is a hub. It's a travel hub, unlike Uganda. We get so many travelers within our country from different corners of the world. If you look at the map, actually, even the African continent, Kenya is right in the middle. So the travelers are coming in from all angles of the entire globe. That's the first thing. The second thing is this. If you are to be honest, let's not blame the children. Let's not blame schools. Our political leaders have put us in this current situation. Why? Because immediately the curve had been flattened. Immediately you had a very low risk, low infection rate and transmission rate in the community. We have been taken through heightened political activity, very big rallies for the last 3 months, January, February, because of the political agenda. Now, in those rallies, there was no observation of COVID-19 protocols. People are not wearing masks. And true to it, most of the politicians have become victims to this. So, the political leadership of this country has failed us at this point in time, and that is why we are in this phase that we are in. And I hope it will be a lesson that even after we've managed this current phase or wave, that we will not see, because the political leaders are the ones who set example for the people. If they don't set the right example, the average Kenyan will actually follow. And so we'll keep going into waves and waves and waves and waves. But more importantly, we need to strengthen our healthcare system, have it prepared for the worst, so that even when we get to a scenario like where we are now, we don't have to worry about the healthcare system being overwhelmed, because this is what we are talking about now, that, we have had to stop the transmission because our system cannot take care of the people. It's going to be overwhelmed. That is what is really important. So children, I wouldn't blame children. I think at the top, leadership.
But another question for you is, the other day the CS came out and said, mutulete matanki ya oxygen. Nani anatembea na hizi tanki za oxygen?
GB, huna moja nyumbani?
Karibu nilete manila 6 ya cylinder ya gas, labda hii ndio unahitaji. What are these things?
Yeah, I mean, and as I said earlier, we did a very good audit.
It's amazing to live in this country.
Yeah, we did a very good audit of the oxygen supply system in the country, what was required. But let me ask you, when you see the CS coming out, he's also passing a message to us that even within their own system, they've been unable to handle this, and that is why they're coming out in public. Why am I saying so? I think it's not public knowledge that we have governors who set up ICU beds in their homes. Yeah. So those are the people. I mean, the average Kenyan in Kibera, even in where we are now, doesn't have the audacity to go and look for an oxygen cylinder and put it in his home. His worry is basic things. So the people of privilege who have political power, who have political connections, are the ones who've hoarded the oxygen cylinders. And it is interesting that now the ministry can come out and say, you're hoarding them, bring them back, put it out in the public. I mean, who has the machination or the machinery to actually go and say, we want to see where the oxygen cylinders are, and we take them for the public? It is the same government. So it is them. They should tell us where it is. Tell us. I think that's what you should have asked us as the media. So where are these cylinders? Yes. I mean,
there's something I've sent you on WhatsApp, and it's about the vaccines and the effectiveness and all that. What are your thoughts on that? Because I think Kenya is also raising questions, when you find that we are being restricted into one vaccine and then the information is coming out on the rate of effectiveness. What's your argument on that from a medical ground?
Okay. I'm still laughing about the other, the cylinder issue. because it's
Uko na
almost
ngapi, daktari?
it almost sounds like cylinders are illegal guns. You know, they announce and say, kama unakona bunduki bandia, tafadhali rudisha.
When they actually announced, I was telling my guys, tafadhali, if you have an extra gas cylinder, tafadhali peleka. I didn't know kumbe ni cylinder.
These things are expensive. They cost 40,000. So they are largely in hospitals, actually, and also in people's homes.
They're in hospitals.
But, yeah, because you have many of them, then you don't have money to refill them, so they're in the store. And then hospitals keep borrowing from each other. So it's actually a system that needs to be checked.
But they're not asking for oxygen, they're asking for tanks.
Yeah, because those tanks, there are many of them that are unfilled and they're in stores. Yeah, so it's
So
actually
let me
very-
ask you, doctor, if I go to hospital today,
Yeah.
and have been given, I saw also Baba had some tongue on the side, some picture he has taken. So unapitishanga kwa dirisha, or do they know you've taken it?
That thing is
Because it's
heavy.
very simple.
That
I
thing
mean,
is
there's
heavy.
records.
That thing is heavy. That thing is almost 70 kilos.
The
Almost, some of
government
them,
does not know where these things are.
that thing is heavy. You can't put it in your pocket. They are 70 to 100 kilos. They're big.
So okay, how is the government
They're big.
asking us for tanks that they know?
They even use trolleys to move them. So they are somewhere in stores and people's homes, and majority of them are in stores in hospitals. Anyway, the question you're asking is around vaccines. So let's explain that there are many COVID-19 vaccines, not only AstraZeneca. Now, those vaccines, I will list the ones that have been approved by WHO. One is Moderna from the US. Secondly is Pfizer from the US. Third, we have AstraZeneca from the UK. And then we have now, more recently, J&J, Johnson & Johnson, which is US. Now, there are other vaccines also that are lining up inside the approval system of WHO to get approval. Now, why is it we only have AstraZeneca? Because of distribution and supply logistics. This is it. So, number one is that Kenya's vaccines are predominantly, not predominantly, 100%, if you remove the few doses of Sputnik that have been given. They have been given to Kenya by what we call the COVAX facility, or the COVID vaccine facility. The COVID vaccine facility is a partnership between WHO and the Global Vaccine Alliance. Now, maybe Kenyans do not know that we vaccinate children in this country in their millions every year. In their millions. We give children vaccines for pneumonia. We give children now we have HPV for stopping young girls from getting cancer. We give children vaccines for polio. Where do Kenyans think those vaccines come from? They actually come from the Global Vaccine Alliance. The same place the COVID vaccine is coming from. So this vaccine alliance is the one that negotiates on behalf of countries that are not rich. Let's not say poor, because Kenya is not poor, but it's not rich. It negotiates on behalf of countries that are not rich, and then buys in bulk with donor money from multiple donors, and then delivers. Therefore, it means that they then have to negotiate for what's available. So out of the ones that WHO has approved, Moderna, Pfizer, AstraZeneca, so far, Pfizer cannot be brought here. You know, can you imagine maintaining negative 70 degrees in some of the parts of this country? Negative 70 is not even available in Nairobi, except maybe in research laboratories. So therefore, the Pfizer doesn't become one of the ones that are available to us for large-scale rollout. Same with Moderna for negative 20. Therefore, the one that's available for the COVAX facility that comes here, that is available also in huge quantities, is AstraZeneca. Why is it available in huge quantities? Because the company that did the research on AstraZeneca did a manufacturing contract with the biggest manufacturer of vaccines globally, which is called the Serum Institute, meaning that the only vaccine available for large-scale rollout in the countries of Africa and Asia is AstraZeneca. So that's the mapping. But in terms of effectiveness, as was said earlier, the first thing I want to tell people is that this comparison, that this one only works 60, 70%, this one is 80, this is 90. The first thing I want to disabuse is that effectiveness is not in your body. Your body, when it works 100%. This is population level. It is saying that if I have 100 people who got this vaccine, we were able to protect 30 of them, or 60 of them, or 90 of them from going to severe disease. You can't have some people getting 70% severe disease and 30% severe disease. So when it protects you, it is 100%. But in a population study, it protects this number of people, this percent of people against severe disease. So for you, it works 100%. That's one thing people need to remember, not 60, 70%. It works 60, 100%. The other thing that was said by Dr. is this, that the purpose of the vaccine is not to stop you from being infected. It is to make sure that you do not, it's to protect you from getting severely sick. Okay? Now, when we talk about stopping you from being severely sick, all of them stop you from being severely sick. Actually, when you look at Moderna, Pfizer, AstraZeneca, the controlling or stopping you from getting severe disease, they're all 100%. Okay? So we should stop focusing on too much on these statistics or this and that. As we keep saying, the best vaccine for you is a vaccine that's available for you.
Okay.
Yeah.
All right. I have two last questions as we towards our tail end. One is for MWACHONDA, Daktari, and then another one is for you. So since you are still on the mic, I'll just read out the question for you. From Mike, it says, great conversation. I would like to hear Dr. GITHINJI's view on epidemiological advice informing the president on lockdown and curfews without an elaborate plan for mass testing and mass vaccination. Are we just sitting in there and waiting for the positivity rate to drop to below 5%, open up again, cases go up, lockdown and curfew, vicious cycle counties?
So the data that is used, and I was, somebody was asking this question yesterday, that number one is that we must remember that the infection is not the problem. So no lockdown stops infection. The lockdowns or the cessation of movement reduce the force of transmission from one person to the other. When you have everyone congregating together, then it's possible that one infected person passes on to 3 people, for argument's sake. But when you reduce movement, it is possible that one infected person only infects one other person, or 1.5 people, meaning you're reducing the force of transmission. That's what we call flattening the curve. Why do you want to flatten the curve? You want to flatten the curve because if you have only 100 people infected and maybe one of them requires ICU, you can then do the multiplication and say, what if we have 1,000 people? Then you have 10 people requiring ICU. What if you had 1,000,000 people? Then you have 10,000 people requiring ICU. You see, now that's what you need to watch. You need to watch the people who require care, because the moment they require care and you can't provide it to them, then you have preventable loss of life. So that's what balance is, whether to slow down movement or to stay. So the one way out of this would be to build the health system. If we had, for example, 3,000 ICU beds and we had capacity to provide 50,000 people, 100,000 people oxygen, we would not have cessation of movement. This is the point, that our cessation is driven by our capacity of the health system. By the time the president was putting the curfew and the cessation of movement, people could not find beds in ICU. People could not find oxygen. You've seen even Kenyatta running out of oxygen. You've seen the ministers were discussing asking for cylinders. Why are we have never had a minister ask for cylinders before. Why now? Because our oxygen consumption has gone up almost 5 times over. So if we can actually increase our health capacity, have more oxygen available, have more beds available, have more doctors and nurses available, and have space for people so that if you have difficulty in breathing, we can give you oxygen right now, you're okay and you go back home. We can protect the economy.
Okay. For you, Dr. CHIBANZI, Simeon Hayengo says, AIDS is caused by HIV virus and the world never worked hard to develop a vaccine. Now, why does the world tell us to get vaccinated against COVID virus? COVID virus is only 1 year old. AIDS has been here with us.
So let's start with one thing, the mode of transmission difference between HIV and COVID-19. COVID-19 is a disease that has shaken the entire world. Why? Because if the 4 of us seated do not have a barrier, that's a normal activity. You're just conversing. You will leave here after 1 week, you'll be sick. HIV is not that. HIV is a sexually transmitted disease, which means by the time that activity happens, a lot of effort has gone into it. COVID-19 is transmitted with minimal effort. Me talking to you without a mask, and I have COVID, I've transmitted it to you. So what has been the result? We have seen the way it spread like wildfire. You know the way you can put a matchstick on dry grass in the savannah and it becomes wildfire. That is what COVID-19 has been in the world. And out of that, we've seen the healthcare systems being overwhelmed seriously. Lack of oxygen, lack of ICU space, critical care, doctors, nurses, dying frontline healthcare workers. HIV does not kill as fast as COVID. That's the other thing to consider. And that is why the efforts to actually develop that vaccine very fast were important, because then now, if you don't do that, the global population will be wiped out. But also, if you look at the risk and if you look at the mutation between HIV and COVID, HIV has multiple mutations, but it's because also it takes a longer period to take you down. So people are living with HIV for years, decades, But do we have people living with COVID for decades? You get COVID, it's a matter of a spectrum. If you're on the mild, moderate, you survive. If you move to the severe
You're done.
form, you're dead within days. And that is why there's been a lot of effort to vaccinate and get people vaccinated for COVID. Again, it is not a conspiracy theory. Because I saw the question. The question is that because there's no vaccine for HIV, there's a vaccine for COVID, then you're saying that we're trying, there's something fishy, you're trying to wipe us out, or there's nothing like that. It's basically out of an intention to protect the
But for decades, why have you not developed a vaccine for it? Even if the
research that is there, I think malaria. Good. Malaria. How long have we had malaria? We've had malaria for decades, but for the first time is when now we're talking about a malaria vaccine. So the diseases are very different. And by virtue of that, then you cannot compare apples and oranges. You can't say this is an orange, this is an apple. So you can't. You see, those are different. And that is the reason why, basic as that the disease, the viruses are very different in their transmission, in their effect of causing severe disease, the duration it takes, and even how it is transmitted. And that is why the most effective way of managing HIV is antiretrovirals, because they suppress virus replication in your body to prevent severe disease. Severe disease is where you're wasted, and then that's all the other opportunistic infections come in. But with COVID, you get the virus, it replicates so fast in your body, it causes an immune response, overwhelms your system, and within days you are down. Within days.
So it means HIV is complex. We cannot find a vaccine. Or
yes, it is. It is not as simple as what we'd say with COVID. The research is still ongoing. But honestly speaking, it's more of ARVs than the vaccine that will help us.
Cool ARVs.
Yeah.
Anyway, now there's a statement that was made. And anyway, that's a discussion for another day. I'm not yet happy with that because we live with it because it does not finish us very quickly. But anyway, we'll try to find a way to fix it. Now, there's a last question for both of you guys. I had a doctor here, Dr. Waumengaria, who is a chair, I think should be the chair of Catholic doctors.
He's a member. He's a member.
Okay. Yeah. He was here. And he said that COVID has treatment. So why are we vaccinating people?
COVID has?
Do you want to answer that? So let me tell you this, that number one, I think I just wanted to add a joke to the conversation you had earlier, that actually the vaccine we really need is our ability to elect bad leaders. That's the vaccine we need. We seem to be over and over again.
We need to vaccinate ourselves again. We need to
vaccinate ourselves. But perfectly explained. I mean, and there's still research, and the vaccines will come, even for malaria, even for HIV. Just the difference in the viruses. Now, so far, there have been a lot of conversations around possible treatments. You see, for HIV, when we took very long and people were dying, there were treatments that were tested. Now, the treatments that we started with treating HIV are not the ones we're using now. Science has progressed, and that's why now HIV has even been considered a chronic disease, just like hypertension or diabetes. There's medicine, it's treatable, so we'll find a vaccine, but in the meantime, it's treatable. So it's a chronic disease. It's no stigma, nothing. It's just like hypertension or diabetes, you can be treated. For COVID, there is a lot of research on different molecules, but none of them has been confirmed to actually treat the disease. You hear? And a lot of these studies that you find, if you have 100 people of COVID and you give them this and you say, oh, by the way, 90% survived, you need what we call a double-blind trial, which says that this group that I gave this treatment and this group I did not give this treatment blindly, what's called placebo, when the result came, the group that got this one survived better than the group that didn't get this one. But you can't say, I treated 100 people with this and only one got severe disease. You don't know whether they would have survived actually without your treatment because you didn't have the double-blind trial. The next thing is that some of these medicines have other harm to your kidney, to your heart. So you want to confirm that they have actually benefit over COVID before you say they're good and you can try them. But there's a whole plethora of possible treatments that are being checked. And who knows, maybe in the next 1 year or even fewer, we'll find a medicine that actually treats. But there's none that now we can present substantive scientific, peer-reviewed evidence that says this one. Because if it did, why are we? Let me ask you, GB. We have lost loved ones. Okay.
Yes.
I have lost loved ones. Two of my friends have lost their fathers. I've lost a very close friend. I'm sure Dr. here has lost close ones. If we knew there was a treatment for COVID, why wouldn't we have given it to them secretly? Are you getting me? So
They do have to do it secretly.
So, if we knew we don't tell people, but we know it's there, then we could have given it to them. You know, I lost a close friend the other day, and we even tried some of those medicines. We went, the doctor even bought remdesivir. I was in Roy Family Hospital with a father of a friend. They were looking for these drugs, but you give them, but the people still die. So there is no confirmed treatment for COVID-19.
Actually, Ome said you'd want to be held accountable. If you do you have any comments on the same?
Yeah, let me add this. And in just as what he was saying, that if we knew the treatment in typical Kenyan style, we'd be making money out of it right now. But now there's none. But then let me say this. If you look at how COVID-19 patients, especially those who get severe COVID disease, where does it really bring a problem? Where are people requiring oxygen? Where are people going into ICU? Because it destroys the basic function of your lungs. That is the alveoli, where the gas exchange happens, are obliterated. So your lung is supposed to expand and contract, expand, and you breathe in and out. So what COVID does is actually kills your lungs. It destroys your lungs. Your lung stops expanding and contracting. Your lung becomes hard like rubber. So the degree of your lung being affected determines whether you live or die. I've seen so many of those CT scans where it progresses progressively from your lower lobes to the entire lung. The minute it affects 95% of your lung, you're not able to breathe, because it is 95% is done, is as hard as rubber. It can't expand and contract. You have 5% of your lung capacity. There is no medicine that you will give that will change that effect in your lungs. And that is why people are dying.
Once your lung is destroyed, it's destroyed.
It's destroyed.
You cannot fix it.
It's mechanical.
There's no reversal.
Unless you go, if you're talking of your engine having died because the pistons are not moving, you have to open up the engine, remove the pistons, fix new ones, and do what? And so now, are we able to do lung transplants? We can't.
Yeah.
How many people? So that's the basic principle of
It's
why
mechanical.
It's mechanical. The effect of COVID on your body becomes mechanical in your lungs, and that is why people are dying.
Wow. I'll call Waome and hold him accountable for that.
No, hold them accountable. And you know, what I want to add is that, you see, what they're doing is they're taking people who have mild COVID, who are going to recover anyway, and giving them all these kinds of things that they're giving them without any confirmation of whether they actually worked or not, or the person just recovered.
Okay.
So that's critically important. But let's also say that, just eating a healthy diet improves your immunity. Okay. We do not know that if you have a risk like diabetes or hypertension, it may still overwhelm you. It will still overwhelm you. But keeping a good immunity by taking, good diet and fruits is not for COVID. It's generally, it's good for us. So if somebody tells you, please take vitamins, please take them, because they're not bad for you anyway. You should have taken them even before COVID. So we are not saying that we should not take those.
Why are you simplifying the conspiracy that people have taken a lot of time to build?
Take zinc, take vitamins. They are necessary for you whether you have COVID or not. That's the point. But when somebody gives you, somebody told me the other day, they were taking antibiotics and they took them, they were supposed to take them for 3 days. There's actually a guy who had a thread. And they took them for 14 days.
Yes.
And the person started having serious issues. They had to be taken to the hospital. I think the dangers we are putting people into. Okay. So we need to decide that first, preventive measures, number one, most important. Secondly, keep a healthy lifestyle. Avoid smoking, avoid excessive alcohol. That's not for COVID. It's good for you anyway. Take multivitamins, take fruits, keep yourself healthy. But if you need to use an antibiotic, tell your medical professional to use it rationally. Okay? The final thing I want to say is this issue of oxygen, which Dr. has explained. That for COVID, there's a very strange phenomenon where when the lung starts filling up, your body doesn't react the way it should, and you start panting and having breathlessness, especially in elderly people. So it's good that elderly people are being managed at home, that the community health worker or the medical officer or the nurse who is coming to see them at home carries a simple gadget called a pulse oximeter so that they can check the oxygen. We are getting people going to the hospital where the oxygen, well, it should be 99%. They're going to the hospital and it is 70 or 60. But they didn't know. They were just feeling a bit fatigued, maybe some sweating, maybe some confusion. But no one knew because they are told, you're okay. You're not having difficulty in breathing. Stay home. By the time they get there, when they're 60, as has been explained, the lung is so filled up that even if you give oxygen, there's no recovery. So basic measures like ensuring people under home-based care, especially elderly, people with diabetes, hypertension, whoever is checking them, carries a pulse oximeter and checks their oxygen with a finger is critically important. Yeah.
Where do you get the oximeters? Because a lot of guys would want.
I talked about it the other day. For those, we don't want to make this a rich people disease. So number one is that if you can afford, it's 1,500 shillings.
1,500 shillings.
It's 1,500, okay?
Even
It's
a-
available
a
in a local
business idea for the
pharmacy.
week.
It's available. It's a small gadget. You put your finger, you read. It has 2 readings, pulse rate and oxygen only. Very basic. But if you can't afford, don't worry. If you're at home, insist, because the counties are actually organizing for home visits. The person going for home visits should have
an
one,
oximeter.
especially community health extension workers. We should facilitate them. Can you imagine? We have 4,000 community health extension workers in this country. 4,000. If you have to buy each of them a gadget of 2,000 bob, how much money is that? It's not even 10 million.
Yeah.
You can actually make sure that people being seen, there's somebody checking their oxygen level so that you can send the signal for them to go for
Right.
supplements.
We hope they'll release the money soon so that we can get the oximeter. Anyway, Abbas Njuguna on a light note says, I would not be surprised to see a police operation in the garages throughout the country to confiscate oxygen cylinders used by the welders. Huh? Anything is possible. Thank you so much, gentlemen, for coming in. I hope to see you guys again. It's there when you make time. Mwachonda, I wish you all the very best in your pursuits. Na kuna mtu aliuliza swali ambaye sikukuuliza, lakini labda nitakuuliza. You guys, you fight until you're where these people you are fighting are.
What do you mean?
That's where the fight ends.
We fight until?
You get to where those people you are fighting are.
Sijakuelewa.
Okay, let's make it very simple. You're saying Mutai Kagwe is incompetent in the way he's handling healthcare, right? Until Mwachonda is there.
Yeah.
The story ends.
And I'm not sure he said. And I'm not sure he said Mutai Kagwe is incompetent.
Yeah. So let's say that. No, I did not say that.
What I'm saying is, most of the guys in the medical sector would say that he's not handling healthcare the best way possible.
Okay.
And they would suggest best way. They would recommend. They would say this is what should be done until they're in those positions. Then they forget suddenly that they need to see those changes happening.
Well, I'm
Ni kama
not.
bunge tu.
Exactly.
Sasa mimi napiga kelele nasema
Huyu
mwananchi
mzuri
nini?
mzuri
Wacha niingie
ukiingia
bunge.
kule,
Unasikia
the
tena
system
kwa
swallows
kumi
you.
wacho.
The system swallows you. Do you remember all these freedom fighters? They end up in parliament. Then they don't pass any bill, so the system swallows you. You go there and you find
Kuna mashetani.
it was bigger than you thought. You fight
So-
to
so-
buy a laptop, you
It's a
need to do a
monster.
tender, therefore you don't have a laptop for 2 years because the tender hasn't passed. Now, so
The system.
Wacha nibaki na kelele. Siendi
The
bunge.
system.
I would rather remain here making noise.
Yeah. So essentially, I think to say that
It's a domestic problem.
the system, and the system is government, and then there's one senior government official who once told me, I'm here, I have very good ideas, but government is a monster.
exactly.
Because the people who make decisions, you can be put there as a position and your work is to address the public, tell this, but there are people behind you who make decisions
Who pins you at the back?
who the decisions being made are not what you believe in, but because you're the one who is there and it's government directive, you have to come out and do the work. So the what you call the deep state.
The deep state. I actually talked to my friend Oluga one of the days, I think last year.
Yes.
Ask him, daktari. Kuliendaje bwana?
Oluga is a good example. Oluga was on
I
this
knew
side.
he was coming with that.
Now,
That was the angle he was bringing.
now Oluga is having doctors going on strike on him. Okay, because the system.
Reverse.
Exactly. Your idea can be great. You're a great person. So even Mutai Kagwe and the peers and everyone can be great people.
Yeah.
But the way the system works, you can't wake up one morning and say, "I want 3 billion. Give it to me."
No, it's not possible.
It's not possible.
So I think we'd rather remain here. Even I was thinking of becoming MP, but wacha nibaki na kelele.
Baki hapa eh.
Kama huko ndani, kitaenda kiumane tena. Anyway, guys, thank you so much for coming. The tacklers who have been watching us, really appreciate. Thank you so much for joining us this morning. We hope to see you again tomorrow on Sheria Wiki with Dr. Kuru Okot, Barak Muluka, Professor Barak Muluka, and Daktari Ojuang. I wish you guys a very great day. Buy an oximeter. It's better to stay safe than to be sorry. Ama namna gani?
Yes.
Bye.
Better be
Take care.
safe.
This is a tackle, and the tackle ends now. See you guys. We love you.